You know, it'll happen. It'll happen that you're fully focused on their knee, and then someone smart in the office comes in and says, "Oh, Dr. Tiss, did you look at their hips?" "Oh, of course." And then you get the hip X-ray, and that's what you see the skiffy right there, which is a slip. So beware of the patient who comes in with knee pain with a hip. So almost always include that unless there's something really, really obvious. All right, so CT. Does CT play a role? I will tell you my opinion here. I don't, in my practice, CT does not any longer play a role here, a very limited role, I should say. Some individuals would use this to look for the rotation, the alignment, but really it's pretty high radiation, and really everything that you need to look at on the CT, you can get on an MRI if you need to get it. So I don't really use CT any longer. When do you get an MRI? I would leave that, like Dr. Sponsor was talking about before, with the spine. I would leave the MRI, you know, after you send them to us, because if they have something serious enough, you're thinking about a meniscal injury or something. Most of the time, you can tell on their physical exam, you don't really need to get MRI most of the time, and that can incur significant delay in treatment and also cost. So I don't think it's important to get an MRI. Sometimes you get it in a patient who has an exam that is not really too definitive. And also, I often get it when I want to define the amount of abnormality. Like I want to see how far off the patella is sitting or tracking, and measure some different parameters on there. If you do get an MRI, it's really important to get a good quality one, and also have a good quality musculoskeletal radiologist. I mean, I look at all the MRIs myself, but I also really depend on our colleagues, and you want to find somebody who really just looks at musculoskeletal MRIs, because if they're looking at brains 1 second, then they just come over, they'll give you a 2-line reading, knee looks normal, but it may or may not be. So you want to get a good reading. So this is what a good axial cut MRI looks like, and the patella is well centered, and you see that the medial structures are intact, which is where that important little ligament we were talking about before is. This is that shallow lateral side, but it looks good. It looks really good. So this is one of my patients who doesn't look quite so normal. Number one, all this white stuff is an effusion. That's the fluid in the knee. And you also see some of the cartilage has been knocked off. Okay, this may even be that one girl that you looked at, because the cartilage has been knocked off here. There's also some cartilage knocked off here. That's some chronic subluxation. That's where it rides. This is another one where not only a different patient, where not only is it subluxed, but it's also sitting more proximal. So it's sitting above the groove. If you notice how shallow that groove is right there. So the first thing is rule out a fracture. I'm going to say it again. And if you see them in the office, most of the time you don't have any fancy braces there. So do you all know what a knee immobilizer is? Yeah. So a knee immobilizer is that Velcro, big, rigid splint. So you can put them in a knee immobilizer to start with. Rule out a fracture first, okay? And then I like to change them to a hinged brace, you know, after a week or two. You want to start them moving, because otherwise if you leave them in a knee immobilizer for more than 4 to 6 weeks, like we used to, a long time ago, that's what we used to do, they get pretty stiff. And I like to return these kids back to sport. And I think that's important, or at least back to activity where they can bend their knee. You can let them weight bear on this. If there's no fracture, you can let them put full weight, and that's a huge help getting them back to school, okay? Because if they have to walk around with crutches, often they won't go back to school. So you can let them weight bear in that knee immobilizer, okay? And then after a week or two, you put them in a hinged brace. What I do before I ever consider getting an MRI is I see them back in 3 to 4 weeks. Okay, that effusion, that big fluid collection should be completely gone. If it's not completely gone, then you need to start thinking, is there something else going on? At that point, they're pain-free enough, I can look for loose bodies or any problems that are impeding motion. And then I start really increasing their bending 15 degrees per week. If they're still pretty stiff and they're not bending, I make sure I get them to therapy and I start increasing their flexion 15 degrees per week. And then I also get them enrolled in physical therapy for VMO strengthening. So this is the three things, and I'm not sure if this one was in your handout or not, but the VMO strengthening, gluteal strengthening, for their balance, and the physical therapist will actually do this gluteal strengthening without even asking about it, because they all are in tune with this. Okay, and then range of motion. Okay, so the VMO is the medial part over here on the inside, and so that's going to pull the patella back from the outside, and that's going to strengthen it and help keep them from dislocating again. So if you just write down VMO, they're going to get that, and that basically strengthens them out. Yep, question?
Just curious, isn't there a 10 or 15% of the population that doesn't have a VMO?
That's a really good question. There was actually I'm not sure if it was our big orthopedic journal about that. I'm not a believer of that. I kind of looked at that and I said, well, they may have a smaller VMO, and that may be that they have a smaller VMO, but you can always strengthen up their medial quadriceps, because the quadriceps, remember, it's four muscles, okay? And so if you strengthen up that more medial part, if you want to call it their vastus intermedius, which is the middle part going down the inside, and strengthen that up, fine. But, I think that the patient that has a weaker VMO and also an insufficient MPFL, they're more likely to recur. And so that's why your recurrence rates in some of these series are so high. So effectively, yes, but I'm not sure I believe that they completely don't have a VMO. So this is the bracing, and you can get these on Amazon. There's 1 million braces now, so they can get these within 2 days. I'm not a plug for Prime, but you can get this brace right off of Amazon on Prime, and this is what you go. There's a big J right here, not for my name, or not for Jay Lee's either, but there's a big J there that keeps the patella from going to the outside in these straps. And a lot of patients, I probably say 60% of the patients say this really helps them. And maybe it doesn't really work to completely stop dislocations. That's what the literature will tell you, but I think it helps them. McConnell taping has been shown temporarily to help. This is McConnell taping, where they pull the kneecap to the inside. Anybody do the Baltimore Running Festival last week? Anybody? Don't be afraid, raise your hand. Yeah, if you go around to any of the big marathons or big races, you're going to find probably 20% of the patients are walking around with patellar taping. Okay, really popular. Okay, and it does work for a few hours until the sweat breaks it down and it loosens. Okay, what are the results of non-operative treatment? Classically, we always treat non-operatively. Okay, because the results of recurrence are about the same. However, there's a couple of recent articles, all right, that actually show a lower in randomized trials, randomized controlled trials, okay, that actually show a lower recurrence rate for first-time dislocators with doing what we call MPFL reconstructive surgery. But in my hands, and I think all of us here and everybody I know in the sports community, almost all of us treat these first-time dislocators non-operatively, because you have nothing to lose as long as they come back, all right? If they start recurring, dislocating a second, third time, then they need something, okay? And that may have to do with like your MPFL insufficiency or their vastus medialis insufficiency. There are some individuals who are going to fail, okay? But we always treat them primarily non-operatively, okay? So these are the patients that you need to send, right away. So obviously fractures, their patella just won't go back in place. And has anybody seen a patella that won't go back in place? Yeah, I mean, It happens every once in a while. And also if they have an extensor mechanism injury. What is that? They can't straighten out their knee. So they can't actively straighten out their knee. Okay. Late referral, these are the patients, they come back and you're scratching your head about. So recurrent dislocations, they dislocated a second or a third time. They have an alignment issue. They're either rotationally out or in a lot of valgus. Miserable malalignment, which is another rotational problem. They have continued swelling. And this is what we do, just briefly, surgery. I don't want to spend a lot of time on surgery since we treat all the primaries non-operatively. So originally, they do a big open incision, and I remember seeing a bunch of friends who'd been treated as kids, and they had this big, long incision and went up and down their leg. And, it worked fine. It had pretty good results. But seeing that pretty much everybody I treat for patellar dislocations are girls, I wouldn't want to do that to either of my two daughters. Okay, it's a big incision. So we have better options now. A procedure that I use, we can do that through a scope. Probably what most people use is they put a hamstring or other ligament to reconstruct the MPFL, but we're pulling it over to the inside. And so that's what we're doing. We're tightening up the inside and we're releasing the outside. Sometimes we have to address the bony anatomy over here by moving that tibial tubercle to the inside. But all of this, even if you include this bony surgery, you can do all as a same-day surgery. And the kids go back to school the next week, so they miss maybe 4 or 5 days of school. So either way. Indications, multiple dislocations, if they have a real big angular deformity, or they're syndromic. The syndromic kids, though, they're difficult, and they're going to have a higher failure rate with surgery. All of them I start with, and you're safe to start them with physical therapy first, though, building up that VMO. That is only going to help them. The options, we won't really get too much into, but you want to look at their anatomy. This is actually a kid who had dislocated many times, and it was interesting. I took a picture because they formed this big scar on the outside. And this was a syndromic kid. They had some autism syndrome and something else that was not defined, and they had this big scar. And their groove is all the way over here, but they had this big scar band and had never been operated on before, holding them to the outside. And so simply, the only thing we really had to do was cut that. I also sewed up the inside, although that probably wasn't as important as cutting this band. And then you'll have to take my word for it because I don't think the video is going to work. But just by cutting that band and tightening them up on the inside, it actually centered their patella. And you can see the groove there. They're centered in there. And so that's often all you need to do. This is a big complex chart about what you need to look at from one of our big journals. Okay. These are the surgical options. How we doing with time? Because I know we're a little bit behind. Yeah, we're ready to go on. What I'm going to do is we're going to go ahead and I'll skip. I had a few cases. We would kind of ask you, go through with the audience what to do, but we can go ahead and skip those, and we'll just go right to questions. We'll take a